I'm going to go through. Oh, today I am going to go through with you guys some of the risk factors for anxiety in older adults and talk about approaches to assessment and diagnosis of anxiety, and then talk a bit about the evidence-based treatments. Um, and to start off with, I'm going to just make sure we're all on the same page about anxiety. So we think about anxiety as a normal physiological response to stress and threat, which is there really to motivate ourselves to take action to keep ourselves safe. And so there's that normal adaptive anxiety, but it's on the spectrum where a certain amount is adaptive, but it becomes unhelpful if the anxiety persists after the threat has passed, or if it's out of proportion to the magnitude of the likely threat, in which case you get anxiety that causes distress or gets in the way of doing what people want to do. And then at the far end of the spectrum are when people meet criteria for an anxiety disorder where the anxiety is actually disabling. And so the anxiety cycle is, I think, a very useful tool for discussing anxiety with our patients. And it's part of some of the material that we've developed for patient education. And it really explains how anxiety goes off the rails from being a normal adaptive reaction to something that is problematic. And it usually is some kind of trigger or an experience of some kind, a thought or a feeling that activates the sympathetic nervous system, which creates these uncomfortable feelings that are hard for people to ignore. And so the brain gets the signal that something's not right, and then can often start catastrophizing and overestimating what the threats are, seeing danger where there's no danger, and underestimating ability to cope. And then the final step, usually for anxiety going off the rails, is this idea of avoidance. So our instincts tell us we need to get away from something or stop doing something, and immediately there's a relief, this short-term relief, like that was right, that was what I needed to do. But in reality, this actually reinforces this idea that I can't cope with this situation. The situation is not so dangerous. We can't learn that. And so over time, it actually accelerates the anxiety cycle, and you can get stuck in this situation where anxiety is now unhelpful and maladaptive. And I'm going to give you an example of this. So this is a healthy 73-year-old man who is diagnosed with hypertension and decides to do home monitoring of his blood pressure. So he goes and gets a blood pressure cuff, and he's checking his blood pressure multiple times a day. And one morning he's feeling a little funny, a bit of tightness in his chest, and he lies down in his bed and checks his blood pressure, and it's high. It's 180/95, the highest it's been. And now he starts thinking that maybe his blood pressure goes up when he lies down, because this is the first time he's ever checked it lying down in bed. And so he checks his measurements over and over again while lying down, and they're all high. And so now he starts getting this tightening in his chest whenever he lies down, difficulty breathing, and he starts to think that it's his blood pressure, and he starts sleeping in a chair next to his bed. And so this is an example of a phobia. So he has a fear of lying flat in bed. And I've actually treated 3 people in my career with this phobia, if you can imagine that. But luckily for this gentleman, the avoidance behavior comes to light at his next appointment with his nurse practitioner. And luckily, she recognizes that something is not right here, that it's probably not his blood pressure that's the problem, and spends some time reviewing the anxiety cycle with him. This idea that he has this thought that the problem is his blood pressure when he lies down. And so when he lies down, he gets these uncomfortable feelings. And he's now engaged in these avoidance behavior where he's sitting up and sleeping in his chair. And that makes him feel better. He definitely feels less anxious sleeping in his chair, but more uncomfortable. But basically now it's reinforcing this idea that that he is in trouble when he's lying down. And when he lies down, he's going to have a heart attack, is the sort of catastrophic thought that he's developed. And so this is actually treated by exposure. He comes into the office every few days and lies down gradually, adding like flatter and flatter on the examination bed. And his anxiety would spike right when he first lies back, but then it comes down after 10 minutes. And then he's able to lie quite comfortably without any anxiety. And so he reaches an agreement with his nurse practitioner that he's not going to check his blood pressure as often or when he's lying down. And he's able to return to sleep in his bed. So this is an illustration really of how anxiety can go off the rails, but how it's possible to get it back on the rails with like a simple intervention here, which was psychoeducation and exposure. So I wanted to spend some time setting this groundwork for 2 reasons. First, as healthcare providers, we need to understand how anxiety works and how to talk about anxiety with our patients. And then second, because the guidelines I'm going to present to you now are a bit different than the depression guidelines, for example, which really focus on major depression. These guidelines also recognize that there are a fair number of older adults who fit into this middle category of clinically significant but subsyndromal anxiety. And we try to talk more broadly about how do we help people manage anxiety and prevent the development of a full anxiety disorder. And so, I mean, you guys, I think, are all subspecialty residents, and so you probably don't have to convince you about why we need older adult specific guidelines. But we do think that older adults are unique in some ways when it comes to anxiety, because it does look different at other life stages. Older adults are not always very good at recognizing or identifying anxiety. And there are all kinds of new transitions at this stage of life that can create feelings of vulnerability or get in the way of normal coping strategies, like if they're, for example, no longer able to drive or aren't able to exercise because of some disability. Older adults also have changes in roles at this stage, right? Which means that if they are exhibiting avoidance, it can be hard to miss. Expectations are kind of low sometimes when it comes to older adults and their functioning. And so if they're not leaving the house much, for example, it may not be picked up as being related to anxiety. And that's associated with this kind of ageism, right? This idea that anxiety can be discounted as normal or expected with aging. And then the ageism can also get in the way of offering effective treatments. This idea that older adults don't benefit as well from psychotherapy, for example, and then recognizing that our pharmacological treatments have to be adapted because they're more vulnerable to the side effects. And so this guideline was designed to provide clinicians with practical and evidence-based recommendations on prevention, diagnosis, and management of anxiety disorders. And I'll just quickly take you through how we did it. We used the Guideline International Network method, which involved a bunch of steps, first step was around identifying priorities, which we consulted with our target audience. We developed some key questions to guide our evidence synthesis, which was the next step. And then finally, the last part, which was the developing the recommendations. And all of this was led by a working group. And we also had a lived experience stakeholder group and an external guidance group, where we reached out to some international experts in this topic. Ultimately, we completed 4 systematic reviews that focused on placebo-controlled RCTs in older adults. And for older adults, we defined as those over 65. And so the guidelines would not have been possible without the hard work of this pan-Canadian group of experts, and want to acknowledge all of their contributions to the work. And then also the contributions of a number of different people, including our expert guidance. We had some students and staff, as well as a lived experience advisory panel of 8 older adults and their caregivers from across Canada. So the guidelines I'm going to present are rated in part by the grade method. So that's where, for example, there was a systematic review that we could draw on. And, because this is the seniors' mental health, often there wasn't a large amount of evidence. And so in many cases, there would be some uncertainty. The certainty might be lower than in cases where there are large numbers of studies. But even when there's low certainty, we were often able to make a strong recommendation based on whether someone would be most likely to benefit from the intervention, or in some cases, a conditional recommendation where there might be some specific factors you'd have to consider before recommending the treatment. And then there are some more consensus-based recommendations rated from A to being the strongest to D, which is based on expert opinion. So I'm going to jump into the guidelines now, and starting about how we detect anxiety in older adults. The first recommendation in the guideline is that it's worthwhile being familiar with the risk factors for anxiety. And the important thing here is that aging in and of itself is not a risk factor for anxiety. People don't necessarily become anxious as they get older, with the one exception being fear of falling, which does increase as people get older. But in general, factors like disability, cognitive changes, pain, chronic medical conditions are all kind of the common things that you would expect to be associated with anxiety in older adults, with the protective factors being things like social connection and life satisfaction, and connection to things like spiritual or cultural communities being important protective factors. And so our second recommendation is that it's worth having a tool that you feel comfortable with to use to assess for anxiety in older adults. And so we did a systematic review looking at tools that have been validated in older adults. The news wasn't great in that there weren't very many that were well validated. The best one was the Geriatric Anxiety Inventory, the long and short form. And so there's no question that that's the most valid tool in this population. But it's one that's not freely available. They have it's commercial, and so not that easy to use in clinical practice. And so we did look at other tools, things like the GAD-7 and the Hospital Anxiety and Depression Scale, which are less well validated in older adults for anxiety, but have some validity. And so you might consider those as options as well. And in dementia, the best scale is the RAID scale. So once you've identified someone with struggling with anxiety, then we move on to assessment. And so I'm going to start off by telling you about Mrs. Bechter. So this is an 80-year-old woman who has some mild dementia, and lives on her own though in an apartment. And she has a daughter who visits a few times a week. She's caught a cold and she's having trouble sleeping over a few days. And then she starts getting up and calling her daughter in the middle of the night, asking her when she's coming. And so after 1 week of sleeplessness, her daughter gets frustrated with this and takes her to a walk-in clinic. And she says, my mom is so anxious. She's waking up at night and she's calling me. Can you please help me? And the walk-in clinic prescribes her lorazepam to help her with her sleep and anxiety. And she does sleep better the first night, but the second night she's much worse, really confused and anxious, and calls her daughter and says there's a stranger in the house. And her daughter rushes over and finds actually that she's fallen and she's hurt herself. So she takes her to the hospital, and the emergency physician does their assessment and finds that she has pneumonia. So she gets prescribed antibiotics, the sleeping pill is stopped, and her daughter moves in with her for a week. And at the end of that week, her anxiety and sleep and confusion have all improved. And so this is a case that illustrates an example that anxiety is not always an anxiety disorder. And that we really have to think about the upstream factors that cause anxiety, because anxiety is a signal of stress, threat, or danger. And so it's really a downstream signal. And so we really need to look upstream to see what are those factors setting off the signal before we can conclude really as a diagnosis of exclusion that it's actually an anxiety disorder. And older adults are particularly vulnerable to all of these things. And so after you've identified an older adult with anxiety, the next step is a comprehensive assessment. And so as part of the guidelines, we have prepared this kind of assessment algorithm that sort of shows how the diagnosis of an anxiety disorder is really like the last step after you've gone through the assessment, thinking about all these different factors, including, for example, other mental health symptoms, right? Are they anxious because they're delusional? Like that's an important thing to consider. Are the anxiety in older adults can sometimes be an atypical presentation of mania, right? Like it's an important symptom of depression. So we really need to think about other mental health conditions. And thinking about their circumstances, what sort of stressors they're facing, for example. And then really try to nail down how long these symptoms have been going on for, how severe they are, and their nature. So are we talking about worry? Are we talking about panic? And are they showing avoidance, right? So what has been their response to this anxiety? Like at what point are they at? And once you've assessed all of this, you're in a better position to make a diagnosis. And so we have a recommendation around specifically the relationship between anxiety and depression. And the important message here is that anxiety in older adults can be a presenting symptom of depression. It's not atypical that an older adult may not say much about their mood, but be presenting very anxious. And so, and this is particularly important because anxiety is a risk factor for suicide, particularly in conjunction with depression. So someone presenting with anxiety, especially if it's new or of recent onset, you have to have a high suspicion of depression. The other recommendation here is around medical conditions. And so there is a whole table, this is just a section of the table, but a whole table in the guideline of medical conditions that can contribute to anxiety. So some medical conditions actually make physical symptoms that are anxiety generating, like shortness of breath in COPD, wearing off in Parkinson's disease, for example. And in these cases, the treatment is optimizing the management of the medical condition. But there also could be anxiety related to adjustment, as for example, if someone has a medical condition that's getting worse. And then anxiety is important in this context because it can actually be a barrier to people getting the appropriate treatment that they need. And it acts as an amplifier of certain physical symptoms, such as pain, right? So if you have someone who's in pain and is anxious, you can actually turn up the volume on the physical symptoms. And so anytime you're dealing really with acute or subacute late onset anxiety, you really need to raise the alarm about the possibility of a medical condition. Um, and then the guideline also includes recommendations about medication history. And there are, of course, a whole host of medications that actually make anxiety worse. And just to touch on a few, we're talk about anticholinergics, antidepressants, antipsychotics. We have an older adult, for example, who's making mistakes with their medication because of cognitive issues. They could be taking too much of their thyroid pill. They could be messing up their digoxin. And then, of course, substances and stimulants such as caffeine. And I always give this example because if you guys have ever gone to the pharmacy and tried to purchase acetaminophen, mixed in with the regular acetaminophen is acetaminophen plus caffeine. And each one of these tablets contains as much caffeine as a shot of espresso. And so if you have not very good eyes and you can't read on the label that this is a caffeine tablet, then you can imagine an older adult might be overdosing on caffeine. So I'm going to move on now to treatment because I think this is probably where a lot of you guys are interested in hearing about approaches. And the first treatment recommendation is that we generally prefer to take a non-pharmacological approach for anxiety in older adults, of course, knowing that there may be circumstances where you might consider starting with medications. And the approach that we talk about is a stepped care approach. And so the first one is really doing that assessment and thinking about what the underlying causes are. For like example, if they're in financial stress, like helping them to be connected to someone to support them with that would be addressing an underlying cause. And then really working with them around different supportive and self-management strategies. And I'll tell you more about what those are in a second. And then where that's not working, then moving on to psychotherapy and or medications as the last step. And so there is evidence for a step care kind of approach, not so much for treating anxiety disorders. So if you have someone where you can diagnose an anxiety disorder, the evidence is not there necessarily for that, but for people who are presenting with anxiety symptoms, and that this approach actually prevents people from developing anxiety disorders. And so the self-management strategies that form part of our step care recommendations, the first one is like bibliotherapy. Second is relaxation therapy, like diaphragmatic breathing or progressive muscular relaxation, and then mindfulness, and finally social prescription. And so like I gave in the example of the Mr. Christie with his high blood pressure early on, understanding anxiety being so important to overcoming it. So reading about it in the form of some of these self-guided resources can actually be very powerful. And then we know there's pretty good science between breath work and other relaxation techniques. And so that's a really worthwhile intervention. And similarly, the science supporting mindfulness is good. And finally, social prescription is an intervention that gets at this risk factor of social isolation. And finally, we did find evidence in a systematic review that exercise reduces anxiety symptoms. But we didn't find any evidence that it is effective for improving anxiety disorders per se, but certainly enough to suggest that you could include exercise as an anxiety self-management strategy. But we know that some people with anxiety get very stuck. They're unable to benefit or engage in self-management. And in these cases, more intensive psychological interventions like psychotherapy can be explored. So I can tell you about here, Mrs. Lee, who's a 78-year-old widowed woman who lives in an apartment with her daughter. She has well-managed chronic health conditions, and she's been a widow for about 2 years. And in the past year, she's developed a pretty intense worry or preoccupation that she won't be able to continue to live in the apartment, and that their daughter was going to put her in a nursing home. She's initially very reluctant to be assessed for this because she's worried that the assessment will say that she has to go move into a nursing home. And she's really been a worrier lifelong, but the family say that she even though worrying was a big part of her life, it's not really been a problem for her. But now she's worrying every day. It's hard to control. She can't sleep. She's tense. Her mood is irritable. She stopped going out to church. She says, I keep busy around the house, but her family says that she's more restless than busy. And she doesn't really endorsed feeling sad or hopeless, but her anxiety inventory score is 15, which would put her in the criteria for generalized anxiety disorder. And so she's diagnosed with that and connected with a counselor in the family practice to work on CBT with a focus on cognitive distortions like catastrophizing, relaxation, and some behavioral activation to overcome some of the changes in her patterns. And so the first recommendation that we have is that CBT should be offered to older adults to treat anxiety. And so while the certainty of the evidence is low, we really felt that based on what we found, we could recommend this with some strength. And so we did a meta-analysis and found there were 18 studies that use CBT in a variety of different ways to treat anxiety, mainly GAD, but also other anxiety symptoms and some other anxiety disorders, I think a couple of panic ones. There's a little bit of issues of inconsistency and risk of bias, but overall, there's clearly some benefit of CBT over no intervention. With a response remission rate in the CBT group was about 37% compared to 17% in the no intervention. And the in terms of CBT evidence, what was nice is well, there was like a range of different interventions, and that there was evidence to support both individual and group, and both in person and virtual, and both brief CBT and full CBT. But all of the interventions that were studied were adapted in some way to older adults. So being flexible based on their strengths, for example, which may mean focusing a bit more on behavioral and relaxation strategies and a bit less on cognitive restructuring if someone wasn't really able to participate in that kind of work, or maybe involving a care partner or using repetition and reminders. The interesting thing we found in this meta-analysis is if you compared CBT to other active interventions, so that was either another psychotherapy like ACT, or in some cases, the other active intervention was like supportive counseling. There was actually no difference between CBT and that other intervention. And so while CBT works, we have to recognize that other psychotherapeutic and supportive interventions also work. And so I think it's like takes away that excuse. So where CBT is not available, might consider other options that are more accessible in your area, or even a brief engagement in terms of supportive counseling might do the trick. The second psychotherapy recommendation is around mindfulness-based interventions, and there's a number that have some evidence. We couldn't do a meta-analysis because there were only 3 studies that met our criteria, but all of them showed benefit for older adults. And the one thing that we made it a conditional recommendation only because there were only 3 studies and there were quite selected groups of generally high-functioning older adults. And so whether this helps a broader group of older adults is a little bit unclear. I'm sorry. Take a pause for a sip of water. I'm happy to take any questions at this point while I'm taking a pause, or I can plow on to the medications.
I guess, hi, Dr. Iaboni, it's Maggie. Sorry, I don't have my camera on. I'm attending this from some random room on GIM. But I was wondering, like, I know we're talking about the guidelines and this isn't exactly like practical real life, but like, how often are you actually able to get your patients psychotherapy? Especially, I find it like when I was in Gen Psych, it was really hard, and I'm finding with older adults, it's actually so much harder.
Yeah, I mean, that was one of the things that we identified as an issue. We made a recommendation about needing to find better ways to help people access psychotherapy. I think it's like one of those things where like building up a resource yourself of a list of community-based organizations that offer psychotherapy, like in Toronto, for example, Reconnect has CBT groups for anxiety that are offered. It's just like there are resources out there that are often that are not easy to find, I think. There's the online CBT offered now through the provincial program through CAMH. There's like, I think the resources are out there. It just takes a bit of work to track them down and also engage the older adult in following through. Mindfulness groups are not that hard to find at all. There are a number of online mindfulness groups that are now available, operated out of a number of different hospitals in the GTA. Again, this is my experiences are very Toronto specific, and so I know this does not apply across the whole country. But there are some provinces now that are investing in developing more programs that are to help improve access to psychotherapy. Some older adults have the resources to pay for it, and then you're referring them to community psychotherapists. So I think it's Yeah, it's not, the accessibility is not great, but the, the CBT workbooks, many of them are excellent. So I often, I don't refer people to CBT for panic, for example. I prescribe CBT panic workbooks, which I find are, like, in many ways as effective. Um,
Great, thank you.
okay, so we'll go to medications now, and I'm going to come back to Mrs. Lee. And so she's had 8 weeks of CBT at the family health team. She feels a bit better. Her GAI has gone from 15 to 10, but she's not sleeping well. And she says, can you please just prescribe me a sleeping pill to the family primary care provider? But I guess luckily the provider recognizes that she's still having ongoing symptoms of her anxiety disorder. And so they have a discussion about this, and she opts to begin medication treatment for her GAD. And she starts a trial of sertraline. And after 5 weeks with regular adherence, her sleep is improved, her GI score is now 6, and she's now using the techniques from CBT and is getting back out to her church again. So when do you use a medication? So basically, if non-pharmacological interventions are unhelpful, the anxiety is persistent and disabling, it's when you would start considering a medication. And I'm going to highlight here a few key medication recommendations. So our systematic review found that the evidence most strongly supports the use of antidepressants for anxiety disorders in older adults, primarily GAD, but also panic. There were a few studies that also looked at like persistent significant anxiety that was subsyndromal, and a few that looked at anxiety in the context of medical illnesses, primarily COPD and Parkinson's. And so 7 studies could be included in our meta-analysis, and overall, antidepressants likely reduce symptoms of anxiety. There was a bit of a difference here between SSRIs and SNRIs in terms of reduction in symptoms, where SSRIs were a bit better than SNRIs, but there was actually no difference between them in terms of response remission. So the remission rate was 41% with the drug and 28% with no intervention. We also looked at improvement of depressed mood, quality of life, function, and then in those studies that reported those outcomes, treatment with SSRIs and SNRIs improved all of those outcomes as well. And so in terms of safety, our certainty is quite low, but in general, we didn't find differences between drug and placebo for a variety of adverse events. But these were clinical trials that were not powered to detect differences really in major adverse events between drug and placebo. We certainly know antidepressants are associated with some adverse effects in older adults, so you do have to be careful about titrating them. But we do also need to make sure that we get to appropriate treatment doses, and all of the clinical trials really, no one was treated with what we would consider low doses of antidepressants. They really required equivalent treatment doses than younger adults did. In general, when you looked at the time to response in these clinical trials, it was usually 4 to 6 weeks for initial response, often 6 to 8 weeks for full response. So of course, you have to work with the patient around that, and they want a quick escape from their anxiety, and it's not going to provide that. And it's also helpful to recognize that the response rate to the antidepressant was about 40%. So if they don't respond to their first antidepressant, the optimal next step is really to switch the agent and try a different antidepressant. And one great thing that is part of the guideline is that it links to Jerry Medrisk infographics for each of the drugs that talk about how to prescribe them. So these are the first line drug. Duloxetine dropped into second line because of its drug interaction risk, but otherwise the first line were SSRIs and SNRIs. There are some antidepressants that are not on this list, and I get asked about them every time I present, so I made a slide. So we chose not to include fluoxetine, paroxetine, and fluvoxamine because of their unfavorable side effect profile in older adults. Although fluoxetine and paroxetine, there were positive clinical trials for both of those drugs. So I wouldn't necessarily take someone off of one of these drugs if they had been on it lifelong, but certainly we would try not to start them first or second line. Mirtazapine and trazodone have zero evidence for anxiety and anxiety disorders, not just in older adults, but in younger people as well. So they did not land on this list. TCAs not included because of their unfavorable side effect profile, and any of the newer antidepressants also have no evidence in this population. So that's the SSRI recommendation or antidepressant recommendation. The next recommendation is around benzodiazepines. And so here we provide a conditional against recommendation, which is that in general, benzos shouldn't be used to manage anxiety in older adults, except in some limited circumstances, including short-term use until first-line treatments become effective. And I guess the reason why I want to highlight this for you guys is that you may be surprised to know is that there are only 4 studies in the history of psychiatry that looked at benzos for anxiety in older adults. And the longest one was 4 weeks long. And these studies were really problematic. One of the studies, or 2 of them, they actually withdrew people from their existing benzodiazepines and did like a 1-week washout and then restarted either placebo or benzodiazepine. And so what are we treating there? Probably benzo withdrawal, not actually anxiety. We know from our work that tolerance and dependence are very common with these medications. And that while there's no doubt that a benzodiazepine provides some quick relief from anxiety, if you think back to the anxiety cycle I presented earlier, a quick escape from anxiety actually is powerful reinforcement for anxiety. So you get this short-term benefit, but in the long term is detrimental to someone actually being able to overcome their anxiety. And so we basically say we try to avoid using these medications for anxiety, but there may be circumstances where someone has such a severe anxiety disorder that they really need this for symptom management short term while they're waiting for their antidepressant to take effect. And so we give some guidelines about if you are going to prescribe a benzodiazepine, how to prescribe it safely. And like, honestly, by the time I go through this conversation with the patient, half of my patients don't want the prescription anymore. But like, if this is true informed consent, right? You are actually telling them what they need to be aware of. And so that's including talking about whether they have a risk of benzo use disorder or a history of that, and about the limited benefits that we know in terms of long-term use. And then developing this shared understanding about the plan, about how you're going to monitor it, what the risks are, and then being careful about the selection of the benzo and moderate the dose. I'll just quickly touch on buspirone. There was not a lot of evidence for buspirone in older adults. Specifically, the clinical trials were kind of unconvincing, but they did show some benefit for anxiety for doses ranging from like 15 to 60 milligrams a day. The longest study was 6 weeks long. And it's not even really clear, like they were older studies. Only one study required the person be diagnosed with an anxiety disorder. The other 2 studies didn't. So ultimately, we couldn't, we didn't feel like we could say, yes, buspirone is a very effective treatment for anxiety in older adults, but it does have, some benefit in terms of people who can't tolerate first-line treatments like antidepressants. And so it may be an option in those circumstances. There were 2 other drugs that had been studied in randomized controlled trials in older adults. The one was quetiapine XR. And based on our review of the 1 RCT, we made a conditional against recommendation also for quetiapine. And that it's basically, there may be circumstances where you might consider it, but in most circumstances, you probably would not use quetiapine to treat an anxiety disorder in older adults. And so there was this 1 randomized controlled trial. There were generally kind of younger old people, very healthy and robust, not a lot of medical comorbidity or cognitive impairment. And the mean dose in this study was like 170 milligrams. And there definitely was benefit in terms of reduced anxiety, remission, with kind of low to moderate effect sizes, depending on the outcome. There was certainly some increased sedation in the quetiapine group. But so I guess we were thought to take this clinical trial and apply it to like the 85-year-old person who's sitting in your office with anxiety is quite hard to do. We know the risks from quetiapine for older adults from our observational research studies, and we know these risks increase with age and with dose and with duration of use. And so, we just basically say that in general, you wouldn't consider this first or second line. You might, in some circumstances, if there's very severe treatment-resistant anxiety, where you've had a thorough discussion of risks and benefits and the kind of monitoring that's outlined in Geri MedRisk, just, consider this as an option. And the last conditional against recommendation is for pregabalin. So there's one clinical trial again of pregabalin in older adults. This is a bit controversial in part, in Europe right now, pregabalin has a approved indication for GAD. But there is only this one clinical trial in older adults, and it was a decent trial in almost 300 older adults. Again, this kind of younger, old, healthy cohort. They got up to almost 300 milligrams daily. But really there was only a tiny benefit, like barely significant, on anxiety symptoms, and no benefit for anxiety remission or response. But there was some question of tolerability related to dropouts in the clinical trial. And so again, based on this idea that the adverse effects of pregabalin increase with age and with comorbidity and frailty and are dose dependent, we thought that to apply this recommendation broadly to a population of older adults is probably risky. And so you might consider pregabalin if you have someone maybe who's younger and more robust, or maybe if they have severe treatment-resistant anxiety, again, with exploration of those risks and benefits and careful monitoring as outlined in the GeriMed risk infographic. I'm happy to share with you guys any links, so you don't have to jump onto the QR code here, but you can access all of these resources online, including the infographics, the medication recommendations, and the full guidelines. I think I have time for one quick conversation about fear of falling. And so I'll tell you about Mrs. Fields, who is 86 and lives alone in an apartment. And she comes to see her family doctor, and she says that she fell 2 months ago after she got dizzy when she stood up to answer the phone. And she was on the floor several hours until the superintendent found her and helped her up. She didn't seek medical attention at that time, but since then, she's been really afraid to move around the apartment. She's been canceling outside appointments. She's actually reduced her drinking and taken her phone off the hook because she's worried that she'll have to run to the bathroom or have to run to the phone. And the worry about this is actually affecting her sleep and her well-being. And when she's seen in the office, she is quite deconditioned. She has orthostatic hypotension. Her vision isn't great, and she actually apparently had lost her glasses. And I spent some time talking about this fear that she has, this fear that she's going to be alone, that she's going to be on the floor, that no one will find her, and she won't be able to get up. And so in this case, the GP focuses on a solution-focused approach. They talk about different solutions that might help her feel less worried. So they talk about getting a falls alert lifeline, having neighbors check on her every day, helping her learn to get up from a fall. But she doesn't want to go to a falls prevention program. She doesn't think she can go. She's too scared of leaving her apartment. And so they set up the lifeline. They book an optometrist visit so that she can get glasses. They get the neighbors to check in, and they do an assessment, a home assessment for physio and OT. And so when she comes back about a month later, she has glasses, she has the falls alert bracelet, she has a four-wheeled walker. She's worked on transfer with the physiotherapist. She has a transfer pole by her bed, a raised toilet seat. And now she's feeling a little bit more confident, and she's willing to accept a referral to the falls prevention program that involves things like exercise balance training and a CBT component. So that's an example of how you approach fear of falling. It's not just jumping to addressing the fear, but also recognizing that there is an element of this that is based in reality, that it may not be, there is often some degree of catastrophizing, but there is some reality to the risk of falls. And so we have to address falls risk factors as well as address the fear. So there were three main recommendations around fear of falling. And the first is to remember to ask about this. And this would be part of your assessment. You ask about falls, and then you can ask about fear of falling. And there are some specific language that we include in the guideline about how to ask about it. And when it becomes clear that if they have excessive fear of falling and where they're starting to engage in some counterproductive avoidance behaviors, and that's when it's clear you need to address it. So like in this case, there were lots of basis of the fear in reality, and you have to address some of the factors that are increasing her falls risk. But then also, you're looking at reducing the risk alongside reducing the fear. And then at that same time, how do you build up their confidence again in their mobility, their the sense that they can cope with moving around their environment. And so in these cases, we suggest using CBT, which but not CBT standalone. It's really the evidence is for CBT incorporated into like a falls prevention program, often because CBT on its own doesn't seem to work as well as CBT combined with exercise of some kind, whether that be balance or strength training. Basically, if you can imagine exercise in this case is like an exposure therapy that helps people overcome their fear of falling. So the last thing I'm going to tell you about is that there are a whole bunch of resources on the CCSMH based on the guidelines, some of which are designed for caregivers, some of which are designed for patients, and some that are designed for healthcare providers. And you can actually even go online and order these to get delivered to you if you want to have some available to give out to people. So that's the end of my talk. I'm happy to take questions, but the summary is you should ask about anxiety, think about all the different factors that are contributing. Don't be shy to provide psychological support, psychoeducation, options for self-management. Um, Even basic supportive therapy is probably better than nothing. And antidepressants are the first line medication when indicated. Happy to take any questions from you guys.
Thank you, Dr. Iaboni.
Should I'll close my slides so that I can see people. Hold on. Hey.
I guess just more of a comment. I see so much pregabalin being used for the indication of anxiety in older adults. So it's really interesting to see that recommendation and see where it comes from the evidence and just, yeah, that difference between the clinical. And I think it's because a lot of the comorbidity with pain, like the idea that you're using it for kind of two indications, but it is helpful to kind of think going forward, is it really going to be the best agent based on the evidence for anxiety?
Yeah. And I would say about like monitoring I mean, I guess if it feels like someone thinks that it's an appropriate intervention, they're starting it for pain, they're going to see if it helps with the anxiety. If it isn't helping, like I think that the hazard is people get left on it, right? Like it ends up staying on their med list forever because people think it's there for pain. They don't realize the indication it was started for. So I think making sure that if there isn't a robust response to it, that it really be discontinued. I think is important because I think that, yeah, people being on it for a long time unnecessarily is problematic. I didn't touch on anxiety and dementia, and I just want to let you guys know that the reason we didn't do that in our guideline is that the BPSD guidelines were being worked on at the same time at the CCSMH. And so if you want the recommendations for anxiety and dementia, those are in the BPSD guidelines and not in these guidelines. We didn't want to duplicate efforts, and so we just sliced it that way.
I just have a question about paroxetine. It is a good anti-anxiety medication for adult population. Um, is this the not in the high in the guidelines for seniors? Is this because of the anticholinergic side effect?
Yeah.
And if it is anticholinergic, how bad the anticholinergic effect is compared to, let's say, TCAs?
Yeah. So yes, it was mainly the anticholinergic side effects that meant that it was excluded in the sense that it's not even in the depression guidelines. The CCSMH paroxetine isn't present as a top medication in those guidelines either. There was also the concern about the how hard it is to stop. It's one of the drugs that has some of the worst discontinuation symptoms. So ultimately, we thought there was a pretty good menu there of options of other medications that we felt that we could recommend, and so it was decided to be left off. I personally started paroxetine in an older adult in a really long time, but I have stopped it. And I would say that in older adults who are vulnerable to so if you again have a robust younger older adults, they probably can tolerate it. But if you have someone who has some limited cognitive reserve, who or MCI, where you are thinking there might be some cholinergic deficit, then it is anticholinergic enough that it can cause quite a bit of cognitive impairment. So those people we would definitely want to avoid it in. I'm trying to remember where it sits on the like anticholinergic burden, but I think it does fit in the moderate category. So it would be like equivalent to some of the other drugs, like maybe not quite as bad as olanzapine, but it would be up there with like amitriptyline, for example. Yeah.
Thank you.
So one of the things I think talking to you guys is like a slightly different audience than I normally talk to with these guidelines, right? Because these are really geared for a huge range of healthcare professionals, from family doctors and others, general psychiatrists and such. And so I'm happy to like talk about, so our patients that we see are often complex, right? And maybe have been through a lot of the first and second and third line type options. So I don't know if any of you guys have any thoughts or questions about that.
Yeah, I'm not sure if you touched on like augmentation, and sorry if you did. I'm following along mostly on my phone. Like, because I think like we often see people who've already had an SSRI trial, right? That's kind of like what happens after that, like if they've already tried the SSRIs. And I know you mentioned switching to another antidepressant, but like when do you consider augmentation and with what?
Yeah, so there is zero evidence for augmentation in the context of anxiety disorders. We couldn't find any clinical trials that have asked that question for older adults. And so generally what we would say in these circumstances, right, is so if they've had one antidepressant trial that didn't work, they have another antidepressant trial. If it works partially, that's interesting. And then you might want, in that case, to think about what you're treating a little bit more carefully. Like, is it an anxiety disorder, or actually is this geriatric depression, right? And in these cases, you might like leap over to the geriatric depression algorithm, and then follow that, because there's this, it's very difficult to disentangle GAD and depression in older adults. There is a lot of comorbidity and overlap. So in someone, yeah, with very severe and difficult to treat GAD, for example, might be MDD that just looks very GAD. I mean, it's kind of in some ways silly that we separate them. You know, it's the same pathways in the brain. It's the, all of what we know about the sort of neurobiology of these diseases are very similar, just they manifest slightly differently. So yeah, so that's generally what I would recommend in a scenario where you just have someone with very severe, persistent treatment-resistant anxiety, is to consider the diagnosis again, and then look to the depression guidelines, where there is more evidence about how to treat more resistant symptoms. So that's generally what we would say.
I'm just curious, like when I read the BPSD guidelines for anxiety in the CCSMH update, to me it was like they didn't necessarily comment. To me, it was almost just like the patient has dementia and then they have anxiety. So like sometimes I think about anxiety being due to dementia, like their anxiety is due to their memory loss and they're not being able to function anymore, blah, 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 blah. But to me, it seemed like they were just saying like, if the patient has a cognitive disorder and they happen to meet criteria for anxiety, like this is what our recommendations are. Is that kind of like your understanding as well, would you say? And
Yeah.
distinct from like, because they only recommended citalopram essentially, which I was like, okay, cool. But and so I'm just imagining like you try citalopram and then you just go back to like, these anxiety guidelines that say, any SSRI or SNRI could be considered first line.
Yeah, I think that, I mean, they were very much also sticking with what was available, and there are very limited clinical trials of anxiety and dementia, and so that was basically why they were somewhat hamstrung, I think. But I would say, like, yeah, I don't think there's anything magic about citalopram. I think fundamentally, you could use any SSRI in an older adult with dementia and anxiety. I would. Yeah, I mean, when you formulate the anxiety, you have to have a biopsychosocial formulation that incorporates like what their experience of the environment is, how safe or vulnerable they feel. Like again, like going upstream, right? Like what is it that's triggering this anxiety? And so is it disorientation? Is it Is it noise? Is it, you can think of a whole list of things. And so, yeah, so I can't remember. I don't know if I think they went into all those kinds of details earlier in the guidelines. Like they talked about the environmental and other, like, caregiver relationships and things that are contributing to anxiety. Probably rather than in the recommendation section. Yeah.
That makes sense. Yeah.
I was going to say that Daniel and I had a case very recently of a patient on a specialized dementia unit who had very severe anxiety that we really struggled to put a finger on what it was, and ultimately the diagnosis was mania. She was a bipolar disorder, and she started on an antidepressant, and she became fully manic, and now is completely a transformed woman on a mood stabilizer and off her antidepressant. So I think it's one of those things where it's really, you can throw lots of things at a symptom, right? But fundamentally understanding the symptom and what's causing it is like 9/10 of the battle.
I think another battle in a different context, in the context of CL, is that oftentimes as the consultant, I feel the pressure from the MRP, from the consulting physician to prescribe something.
Yeah.
Like, I feel like I can share this now that I'm about to graduate. That I sometimes almost feel like I have to reach for something just because that's kind of the expectation. And then so I find it really hard to kind of feel like, okay, I don't feel comfortable actually doing it just because I want to appease the MRP or the consultant doctor.
And if you don't, then they might start it anyway. Like the number of times I see like GAD diagnosed on the inpatient medicine ward and someone's been started on an SSRI when we know that they're delirious and that's the reason why they're so anxious. And so a lot of it is education and communication and being clear about a plan and, and supporting the team in like their need to solve the problem instantaneously when we know that it's just going to take some time. Yeah, there's a good proportion of SSRIs are started in hospital, and that's not really ideal practice, right? Like that's part of what we're getting at with this guideline is like, is this really new onset GAD that started last week? I don't think so, right? Like we need to be careful about those kinds of diagnoses, and yeah. Okay. Great. Thanks so much, guys, for coming.
Thank you. I would like to thank you, Dr. Iaboni, again for presenting such a interesting and very well guidelines. Thank you.
Okay. Take care, everyone.
Thank you.
Okay.
Oh, one quick message is that we're posting a position at UHN, so keep your eyes peeled in the psych news at U of T, or if you don't get that, if you're from outside of Toronto, send me an email and I'm happy to share the posting with you. Okay.
Thank you.